History taking in neurology, an introduction to history taking in neurology semester. Personal history, including name of the patient, gender. Some diseases are more in females, like migraine, multiple sclerosis, meningioma, myasthenia gravis, and chorea. Some diseases more in males, like X-linked disease, Duchenne muscle dystrophy, or some disease due to occupational hazard like lumbar disc prolapse. Age, first decade with common presentation of Duchenne muscle dystrophy, Friedreich's ataxia, hyperkalemic periodic paralysis, while in second decade, Becker muscle dystrophy, hypokalemic periodic paralysis, and Mary's ataxia. In the third decade, inflammatory and autoimmune disorders like multiple sclerosis, myasthenia gravis, or some muscle disorders like myotonia. While in the fifth and sixth decades, cerebrovascular stroke, atherosclerotic types, and space-occupying lesions, degenerative disorders are common. We ask about occupation with hazard of toxin exposure like in lead in battery industries, manual workers with more liability to disc prolapse, farmers with antibilharzial drugs, nutritional deficiencies, stressful occupations carry the risk of cerebrovascular stroke. Ask also about residents. Rural areas carry the risk of nutritional deficiencies and infection, while living in urban areas carry more risk of migraine and toxin exposure. We ask about marital status of the patient while he is single, widow or widower, divorced, and the age of youngest child to search for secondary infertility if we suspect endocrine or pituitary disorders. For example, we ask about special habits like smoking, which is a risk factor in case of stroke, oral cancers, peptic ulcer, chronic obstructive pulmonary disease, lung cancer, erectile dysfunctions, and peripheral vascular disorders. Smoking index is the number of packs smoked per day multiplied by the duration in years. Mild smoker is less than 20 packs per day, moderate 20 to 40 packs per year, and heavy smoker more than 40 packs per year. We ask about smoking of shisha, which is measured by kursi per day. Mild shisha smoker is less than 10 kursi per day, moderate 10 to 20 kursi per day, severe more than 20. Alcohol consumption, which is risk for what is called Wernicke-Korsakoff encephalopathy, myopathy, neuropathy, malnutrition, cardiomegaly, liver cirrhosis, gastritis, and pancreatitis. 10 grams of alcohol equals 1 drink. Also, other drugs of abuse should be asked about. We inquire about handedness. While most people are right-handed because the dominant hemisphere is the left hemisphere, as an example of the personal history, we write a right or left-handed male or female patient named, aged, from, and mention the residence, works as, and mention the occupation, married or single or widower, with how many offsprings, the youngest is how many years old, of special habits of medical importance or not. After that, we will discuss the complaint of the patient, which should be mentioned in patient own words with no use of medical terminology, including onset, course, and duration. Onset can be sudden onset, like in stroke, acute in inflammatory condition, gradual, like in space occupating lesions, maybe insidious onset with no definite certain period of time for onset, like in degenerative disorders. Then we ask about the course of disease, which could be regressive in inflammatory conditions and cerebrovascular stroke, progressive like in degenerative disorders and space-occupying, stationary course in hereditary disorders, intermittent course while patient is completely free in between the attacks like migraine and epilepsy, or remittent with period of exacerbations and remission like multiple sclerosis. We ask about the illness. After that, we discuss the family history. We mention the family history items, either positive or negative, because they are very important in neurological history taking. We ask about similar condition, about consanguinity, about presence of neurological or systemic disorders. We should know that the first degree to marry is the fourth degree. So cousins are fourth degree relatives. Pedigree charts are formed of squares and circles. Blank square means unaffected male, while black square means affected male. Shaded square is a carrier, male, and circles indicating females. Blank circle, unaffected female, black circle, affected female, and shaded circle is a carrier female. We draw the pedigree chart for the heredofamilial disorders, and they are helping to understand the genetic pattern of disease and learn about the condition autosomal dominant or recessive, X-linked dominant or recessive, and this is helpful only in the Mendelian pattern of inheritance. Past history. We ask about past history of similar condition, past history of fever related to the onset of the condition, past history of direct or indirect trauma related to the onset of the condition. We ask about symptoms suggestive of tuberculosis, syphilis, bilharziasis, or their treatment. We ask about otitis media, rheumatic heart disease, drug intake, or toxin exposure. In the present history, we analyze the complaint of the patient. So you mentioned the complaint, onset, course, and duration, and then analysis of the symptoms. What are the exacerbating and what are the factors that decrease the symptoms or relieve it. We ask about other symptoms in the same system and symptoms in other systems and symptoms of other systems in the body with developmental history to be added in children and menstrual history to be added in female, especially if you are suspecting pituitary or endocrine abnormality. Symptoms suggestive of intracranial hypertension like headache, which usually is early morning dull aching headache increased by straining with no localizing value mostly, but if the headache is referred to frontal part, so it is usually supratentorial lesion, and if it is referred to the occiput, it is infratentorial lesion. The headache is not relieved by analgesic and partially relieved by vomiting. The vomiting is projectile, not preceded by nausea, not related to meals, and usually is in the early morning. Blurring of vision due to papilledema, congestion, and obstruction of the venous return with swelling of the optic disc. Symptoms suggestive of cranial nerve affection. The first cranial nerve olfactory. The patient may complain of anosmia or hyposmia, which means loss or decrease of smell sensation, or abnormal smell sensation like olfactory hallucination. Optic nerve responsible for visual acuity and field of vision defect and color vision. Third, fourth, and sixth cranial nerve for ocular motility. Usually patient complain of diplopia or ptosis. Trigeminal sensation in the face and supplying motor to muscle of mastication. Facial nerve motor to the face and taste sensation from the anterior to third of the tongue. Vestibulocochlear nerve for hearing and balance. The glossopharyngeal and vagal nerve for responsible for bulbar symptoms. Spinal accessory supplying sternomastoid and trapezius muscle, which support the neck. and hypoglossal, which is motor to the tongue. We ask about motor symptoms, either positive or negative. Positive or negative. Negative, like presence of weakness or heaviness. Positive, like presence of convulsions, twitches, or tremors. We ask if the weakness is uni or bilateral, symmetrical or not, if there is any diurnal variation, if there is associated pain or sensory symptoms, and it is proximal, distal, or both to reach diagnosis like myopathy, neuropathy, and so on. Sensory symptoms, positive like pain and tingling, or negative like numbness, anesthesia, or hypoesthesia. And we ask which limb is affected first, uni or bilateral, symmetrical or not, affection of deep sensation, and associated motor or sphincteric symptoms. Also, we ask about higher cortical symptoms like convulsions, aphasia, which means difficulty in formulation of speech, or if there is associated cortical sensory. Thank you.